Awesome. All right. Thank you. It's a pleasure to be here this morning talking about caring for long COVID. I have no financial conflicts of interest. I've listed research funding, relevant roles, including I serve as the sepsis lead for a Michigan statewide quality improvement collaborative that I'll be discussing. And then I'm just obliged to tell you the talk represents my views, but not views of US government, Department of Veteran Affairs, or any other organizations that I'm affiliated with. So I have several goals for this morning's talk. First, I want to introduce you to the Michigan Continuous Quality Initiative, or CQI program, talk about the hospital medicine safety CQI in particular, and our My COVID-19 initiative, which was a joint CQI venture. And then I'll talk about what we can do today to enhance recovery for our patients after COVID, as well as after sepsis in general. So the CQI programs are sponsored by Blue Cross Blue Shield of Michigan, and they're part of the Blue Cross Blue Shield's value partnership portfolio. It was essentially a group of programs that are meant to move us from fee-for-service to paying for better quality medical care, better outcomes at lower costs. And so I've listed here the 20 current CQIs that you'll see focus for the most part on specialty surgical care, but this group of CQIs is really growing and expanding recently. And there are new CQIs that are forming currently that are more focused on outpatient care. So specifically CQI on diabetes, health behaviors, and health disparities. And I'm hoping to save about 5 minutes at the end of the talk for Caroline to give a little bit more information about these new outpatient CQIs. So the general structure of the CQIs is that Blue Cross Blue Shield provides funds to the coordinating center and directly to the participating hospitals to support data collection as well as quality improvement initiatives. The coordinating center for these CQIs are housed at University of Michigan, and they serve as a data warehouse or registry. They conduct audits of the data to ensure the quality, perform analyses with the data, generate feedback reports to the participating hospitals, set performance targets, which then get approved by Blue Cross, and then convene meetings across the collaboratives. The participating hospitals submit their data to the coordinating center. They receive their feedback reports and act on those, implement local quality improvement initiatives, and then share their challenges and successes for the collaborative at large to learn. And there are a few key elements that I think are worth highlighting. First, these are all physician-led, right? So in contrast to some other, CMS performance measures, which are sort of like, this is the target that's set from above and everybody has to sort of try to reach that. Blue Cross Blue Shield actually really empowers physicians to lead these initiatives, to identify what they think are the most important gaps, and to set the performance targets. Secondly, these initiatives all have robust data registries, and Blue Cross funds this effort to collect really detailed granular clinical information that can really, I think, improve the validity and the sort of nuance of the performance measures that we look at. Next, we set very rigorous performance targets and are sort of constantly reevaluating those every year. So, for example, if there's things where we feel like there's been consistent improvement and we're now seeing good performance across the board, then we will retire a performance measure because we feel like sort of further pushing that might actually lead to more unintended consequences than better care for patients. So we're constantly every year reevaluating the performance targets that we set for our collaborative. Another unique element is the direct funding from Blue Cross Blue Shield of Michigan. So again, they pay the staff effort for the data collection and for quality improvement initiatives. And I think certainly almost all of our hospitals in our collaborative consistently report they would not be able to do the good work they do without this direct support. Next, the CQIs use a pay for performance model. So these performance targets get put into essentially like an index. And so every hospital in our collaborative gets a score, and that score directly impacts the RVU payments from Blue Cross to the hospitals. And so there's a strong incentive to not only participate, but actually, really work to meet these performance targets. Finally, there's a strong element of networking and collaboration. We have meetings 3 times a year. Those used to be in person. Of course, they've been on Zoom recently, but we hope to be back together again soon. And we really work to try to, hear the voices of the different hospitals to learn what has worked at one hospital that might work at another hospital. The CQIs have been broadly successful. I think Blue Cross feels that there has been a very good return on their investment. These have been cost saving overall. They have resulted in better outcomes, lower costs. And here's just one example of a paper that showed these improved outcomes for the bariatric surgery collaborative, specifically lower 30-day mortality after bariatric surgery and cost saving in Michigan hospitals compared to match hospitals outside of the state over the same time frame. So I'll now move on to talk about the hospital medicine safety CQI in particular, which I'm affiliated with. The goal of this CQI is to improve the care of hospitalized medical patients. And we currently have 62 participating hospitals, but are actually in a period of growth and will be enrolling additional hospitals next year. Currently, we have a large number and they're a very diverse set of hospitals representing different hospital settings and types of hospitals across the state. HMS has been in existence for about a decade, and we have had 5 clinical focuses to date. The first initiative was focused on prevention and treatment of venous thromboembolism, and that initiative has subsequently been retired because it was felt that performance had improved and sort of our efforts were better spent focusing on other areas. We have 2 ongoing initiatives, the PIC and Midline initiative, as well as antimicrobial use that have been in place for several years and continue. We launched a COVID-19 initiative that I'll talk a little bit more about during the first essentially maybe 9 months of the pandemic. And then we're currently in our piloting phase for our sepsis initiative, and that is going to launch to all hospitals in our collaborative in 2022. So I'll give you a little bit more detail on some of the successes of the PIC and antimicrobial use initiatives. So these are some of the process measures that we've focused on. The PIC initiative has been successful in reducing short-term PIC use and reducing PIC use in patients with chronic kidney disease for whom use of PICs may jeopardize their ability to get permanent vascular access in the future if they require dialysis. The antimicrobial use initiative has been successful in increasing the proportion of patients with community-acquired pneumonia that are appropriately getting a 5-day duration of therapy, and also reduce the proportion of patients with a positive urine culture who get treated with a fluoroquinolone, where we feel that there are alternative antibiotics that would be a better choice. And I think that these antimicrobial use performance measures really highlight the importance of having sort of robust, detailed, granular clinical data, because you want to make sure that the patients going into the denominator are the right one, right? That the patients who you're looking at for this CAP 5-day measure really are patients for whom a 5-day treatment course is appropriate. They're having clinical resolution on their therapy. And likewise, that the patients included in the fluoroquinolone measure are people for whom there are alternative antibiotic choices available. And so I think this highlights why this robust, like human collected data is really important to make the measures have good face validity and meaning to our hospitals. Here are some examples of outcome measures. The PIC Midline initiative has been successful in reducing the rate of complications over time and increasing the proportion of PICs that were placed for what was considered an appropriate indication. And likewise, antimicrobial use initiative has been successful in reducing the rate of patient-reported antibiotic-related adverse events, which we see more commonly among people with prolonged duration or broad spectrum of antibiotics. And so as we've been able to shorten duration of therapy and select more appropriate antibiotics, we've seen a reduction in these antibiotic-related adverse events. Next, as has been seen across the CQIs, we have seen that there has been substantial cost savings associated with the initiatives. So we're just in the process of finishing an analysis for the PIC and Midline initiative that's been estimated to save about $29 million over the several years that it's been in existence. And that's as a result of prevention of catheter-related bloodstream infections, clots, and then occlusions that would require replacement of the catheters. And then we're in the process of developing this type of an analysis for the antimicrobial use initiative. In addition to this, improvements in the process measures, outcomes, reduction in costs, the data that's collected as a result of the CQI has also been hugely generative in terms of research output. HMS publishes on average about 10 manuscripts each year. And here are 5 examples of, I think, higher profile papers that have been published just in the past 2 years from the PIC and antimicrobial initiatives. So I'll now move on to talk about our COVID-19 initiative in particular. And I want to highlight that this My COVID-19 registry went live on April 1st of 2020. And so that was just 3 weeks after the first COVID case diagnosed in our state. And I think that very sort of short time between when we were able to launch this collaborative wide data collection really highlights the robust kind of infrastructure and well-oiled machine that the CQIs are, that we were able to go live that quickly. To give a little bit of background about what was happening at the time, Blue Cross Blue Shield had actually paused the CQI work. They told hospitals that, given the extreme circumstances of the pandemic, that they would pause the required data collection and allow the staff working on data collection and quality improvement initiatives to actually have their jobs realigned to best support the clinical mission. But there were still some abstractors for whom there wasn't necessarily like a role to reassign them to. And so we launched this My COVID-19 initiative that was done on a voluntary basis for data abstractors and QI staff that could not be reallocated to support the clinical mission. And ultimately, 38 hospitals across Michigan voluntarily participated, and there was 86 abstractors who worked on about 10 or 12 of our different CQIs that all came together to do data collection for the My COVID-19 initiative. We had some broad goals. This was early days when we didn't know much. So we wanted to identify factors associated with a more severe course, understand the long-term complications, evaluate variability in practice across hospitals, and then work to facilitate improvements in care. And so today I'm just going to share one piece of this initiative, which was understanding these long-term complications. For all patients who were entered in our data registry who were discharged alive, the abstractors contacted them by telephone at 60 days after discharge. And so I'll be presenting results that are published in this research letter that described outcomes for our first 1,648 patients enrolled into our registry. Of those, 1,166 were believed to be alive at 60 days post-discharge, and we attempted to contact them by telephone. In total, we were able to reach 42% or 488 patients who had survived hospitalization for COVID in the state of Michigan across these 38 different hospitals. We asked about their ongoing symptoms and learned that 13% had ongoing loss of taste and smell. And 1 in 3, 33%, reported a persistent cardiac or pulmonary symptom, which they attributed to their COVID hospitalization, most commonly breathlessness climbing stairs, shortness of breath, and cough. And we also had 7% of our cohort that was newly on supplemental oxygen following their COVID hospitalization. We asked about their ability to return to normal activities and found that 39% were still unable to return to the things that they've been doing before the hospitalization because of ongoing health issues from their COVID hospitalization. And among the patients that have been working prior to COVID, 40% were still not able to return to work. And that was due to a mixture of ongoing health issues as well as job loss related to the economic downturn with the pandemic. Even the patients who had gone back to work often experienced prolonged work absence. The median time to return to work after being discharged from the hospital was 27 days. And 15% of our cohort reported that, yes, they'd returned to work, but they now had reduced hours or modified duties due to ongoing health issues from COVID. So I think, generally we found that there was pretty common impact on people's ability to return to normal activities and work following their COVID hospitalization. We next asked about emotional and financial impacts, and 25% reported at least moderate emotional impacts from the COVID hospitalization, and 25% at least moderate financial impacts from COVID. We also asked about specific financial impacts and learned that 1 in 10 patients had used up all or nearly all of their life savings as a result of COVID. And 6% of our cohort reported that they were newly unable to pay for necessities such as food, heat, and housing. And those more extreme financial impacts were more common among our younger patients who are not yet Medicare beneficiaries. Overall, I think that these, really convey the more extreme financial toll that was experienced by some of our patients across Michigan. The study should be interpreted in the context of several limitations. So we had relatively high loss to follow-up. We were only able to contact 42% of our patients that were discharged and believed to be alive after hospitalization. There was no comparator cohort, so we don't know how these outcomes compare to people hospitalized for other causes. And there was no pre-COVID data, so we're not able to say how much of this is definitively due to COVID versus things that pre-existed. But we did try to phrase our questions in such a way that we were isolating things that at least the patient believed were sort of related to COVID and worse following their COVID hospitalization. And so I think that even with the limitations of this study, I think that this data is important for showing that COVID hospitalization is followed by substantial disruptions to normal life for many of our patients, and that mortality certainly underestimates the burden of COVID. I'm just going to share one other study that I led looking at longer term outcomes after COVID. This was done in a different cohort of patients. This was survivors of hospitalization for COVID across the nationwide Veteran Affairs healthcare system during the first wave of the pandemic. In total, there were 1,775 survivors during that first wave included in our study. And these patients had 20% rate of hospital readmission to the VA system. We're not able to capture readmissions to other hospitals in this study. And so that should be interpreted as at least 20% rehospitalized in the next 2 months. And then 9% of the patients died in the 2 months following hospital discharge from COVID. The most common reasons or diagnoses that patients came back to the hospital for were overwhelmingly COVID, sepsis, and pneumonia. I think really indicating that the main driver of these hospital readmissions was this kind of delayed worsening of their clinical course with COVID. And then the next most common types of readmissions were for heart failure exacerbations, which is very consistent with what we see in terms of readmissions after sepsis. Generally, the most common cause of readmission after sepsis is recurrent sepsis and infection, and then heart failure exacerbations or sort of volume-related readmissions are the next most common cause. For this study, we were able to have comparator cohorts. So we looked at the outcomes after COVID compared to matched patients surviving hospitalization for non-COVID pneumonia during the same time period and for heart failure exacerbation separately. So here in this figure, this shows the proportion of patients over time who experienced these outcomes. And in yellow is the COVID, and then in blue is the matched comparator cohort. So you can see when you look out to 60 days post-discharge that the rate of hospital readmission or death is actually lower after COVID compared to non-COVID pneumonia. And we see that very same thing when looking at COVID and the matched patients with heart failure. But interestingly, this kind of distribution over time is really different after COVID versus these comparators, such that you see a much higher rate of hospital readmission and mortality early on in these first 10 to 14 days after COVID, I think suggesting that there's this kind of like period of heightened vulnerability in the first 2 weeks after discharge from COVID. And people have asked, do I think that this is a reflection that we were discharging patients too early? And I don't think that we can conclude that. I think we know hospitals were very full, overwhelmed during this time period. And we also know that as hospital census goes up and up, that mortality goes up as well too. It's hard to deliver care to more and more patients. And so I don't think we conclude that because we see this high rate of readmission, therefore we need to keep people longer. I think it reflects rather that there is this period of vulnerability after hospital discharge. We need to make sure patients are aware of that, know when to come back, and that we have systems in place to kind of monitor patients after they go home from the hospital to identify if they are having this delayed worsening in their clinical course. So I'm now going to move on to this last section of the talk, which is about what we can do to enhance recovery after COVID and enhance recovery after sepsis in general. My research program and sort of academic focus has really been looking at sepsis care across the continuum of care, from early hospitalization through discharge and early outpatient follow-up, to try to improve longer-term outcomes from sepsis. And I think COVID is essentially just a special case, one type of sepsis. And a lot of the lessons that we've learned about sepsis survivorship, I think, are directly applicable to thinking about survivorship from COVID. So it's important to recognize that even before COVID, this was a very important issue. An estimated 38 million patients survive hospitalization for sepsis each year around the world. This is data produced by the Institute for Health Metrics and Evaluation, and it was published just before the pandemic began in March. These 38 million patients each year who survive sepsis, we know from research over the past 10 and 20 years, have poor longer-term outcomes. So, for example, there is a threefold increase in moderate to severe cognitive impairment among older Americans hospitalized from sepsis. So it goes from 6% among people immediately prior to sepsis hospitalization to 18% in those very same patients after sepsis hospitalization. Likewise, there's patients acquire on average 1 to 2 new functional limitations during sepsis hospitalization, things like inability to bathe, dress, toilet independently, that really have profound impacts on their ability to go back and live independently at home after sepsis hospitalization. There's a high rate of hospital readmission, and about 40% of hospital readmissions after sepsis are for ambulatory care sensitive conditions, which are essentially a group of diagnoses for which there is some opportunity that there might be ability to prevent those with essentially more timely care. I don't think, doesn't prove that we can prevent them, but suggests that there might be an opportunity to reduce some of those hospital readmissions. We also know that only 55% of patients who are working prior to sepsis are able to return to work within 6 months. By contrast, 45% of patients unable to return to work who were previously working prior to sepsis hospitalization. Lastly, we've had many studies show consistently there's a high rate of mortality in the 1 to 2 years after sepsis. And in prior work that I've led, we've showed that only about half of those deaths in the 1 to 2 years after sepsis can be attributed to patients' pre-sepsis health status, to their age, chronic conditions, frailty, all the things that put them at risk for sepsis in the first place. And rather, about half of these deaths seem to be directly attributable to the sepsis hospitalization and this direct effect of sepsis in terms of accelerating the progression of chronic conditions. As concerning as these findings are, it's also important to recognize that milder symptoms are even more common among our patients. So things like fatigue, difficulty concentrating, poor memory, cloudy thinking, things that wouldn't meet the threshold of moderate to severe cognitive impairment or a new functional limitation are even more common. And these types of symptoms are nonetheless sort of limit patients' ability to return to work, perform the way that they were performing before hospital, or return to other activities. And so I think still have really important impact on patients' quality of life after sepsis. As a result of the large number of patients who survive sepsis each year and this sort of consistent evidence that there are poor outcomes across a whole variety of different domains, sepsis survivorship was specifically recognized as a sort of a key priority in the 2017 World Health Organization resolution that recognized sepsis as a global health priority. So they specifically called for monitoring progress towards improving outcomes for sepsis survivors, and also for developing strategies for policy change to increase survivors' access to rehabilitation programs. I think even though sepsis and sepsis survivorship was recognized as this priority by the by the World Health Organization, that it was still a relatively neglected issue prior to the pandemic. This is a editorial that was published, it's a decade old now, but I think was pretty reflective of what the general landscape was before COVID. Derek Angus says the lingering consequences of sepsis, a hidden public health disaster, meaning it was something that not a lot of people were paying attention to, but really had a substantial impact on older Americans' ability to live independently after sepsis. And I think that the COVID pandemic has really brought to light a lot of these issues of patients who have slow, incomplete, delayed recovery after viral sepsis. So how can we make things better? I think as I think about this issue, one of the things I think is important to think about is that long COVID and sort of life after sepsis really looks very different from patient to patient. So when we look at this epidemiology and we see, a certain amount of patients have cognitive impairment or emotional impacts or physical disability, it's important to recognize that what that looks like for any one patient is really different patient to patient. So this figure here on the left is from a study looking at sepsis survivors and looks at the proportion of patients with depression, cognitive impairment, disability at 3 and 12 months. And so you see that there's a fair number of patients with each of these issues, but the number of patients who have issues in all 3 of those domains, fortunately, is pretty low. And we really see the same thing with long COVID. So this is a figure that was from a recent study that was published that looked at patients seen at a post-COVID clinic at a large hospital in Paris. And so here in gray, they show 60 patients they saw didn't have symptoms across any of these domains. In red, we see patients with cognitive impairment. Green is breathing issues. This yellow is fibrotic lesions on their CAT scan, and blue is psychiatric symptoms. And so you can see, towards the center of these, there's relatively few patients who have issues across all of those domains. And so I think this heterogeneity to me means that we're not going to be able to just have, this is what we do these and these and these tests, and then we do these and these and these interventions, and then we make people better. But we're going to have to sort of screen people for these different issues and then sort of tailor their treatment going forward. I think that the heterogeneous or sort of variable presentation patient to patient, of course, makes sense because the exposure to sepsis or to COVID is very complex. And so what things look like afterwards is due to the interplay between patients' prior health status, which of course is hugely variable patient to patient, what their actual infection looked like, what was the infectious dose or what variant maybe did they have, what was their treatment, things like isolation, steroids, bed rest, sedation, ventilation are all common things that patients experience during the hospital or during their treatment. And all of those may have negative impacts on people's kind of longer term outcomes. Concurrent events that happen to patients during the pandemic, social isolation, loss of childcare, job loss, death of a loved one. These, of course, have substantial impacts on patients' recovery, and I think are likewise relatively common during the pandemic. So given that things look so different patient to patient and that this is a sort of a complex problem, what can we do? And when I think about recovery from COVID, I sort of think about the metaphor of taking care of really variable, heterogeneous patients, of critically ill patients in the ICU. For example, we see patients with respiratory failure for all sorts of different reasons: COPD exacerbation, pneumonia, aspiration, trauma. And across all of these different reasons, these kind of best supportive care practices that we've developed for patients receiving invasive mechanical ventilation and life support work across the board. So for example, in this clinical trial, the Awakening and Breathing Controlled trial, where they randomized patients to having protocolized daily awakening trials, we turn the sedation off, daily breathing trials if they meet some basic thresholds on the ventilator, where we turn the knobs and simulate breathing on their own. Doing that consistently is associated with a 12% absolute reduction in 1-year mortality and a number needed to treat of 7 patients. So when I have start my rotations in the ICU, that's always the first study I highlight with the residents to say, we talk about all these like advanced heroic things like ECMO or some kind of like, fancy medication, but really it's this kind of team-based supportive care practices, doing that consistently every day for all of our patients, that I think really saves lives in the long end. And I think that it's the same thing that when we think about recovery, it's sort of dotting the I's and crossing the T's and giving these patients the best supportive care going forward that I think across the board can help patients with after sepsis and after COVID. So I'll turn your attention. These are 2 different articles that I've written about recovery from sepsis and then COVID. The first article is a essentially systematic review of the literature on longer term outcomes from sepsis, and then drawing from the few kind of studies we have specifically about recovery from sepsis, but then a lot from related literature. We tried to identify essentially pragmatic best practices across the continuum of care to promote recovery for sepsis. And so this article is divided into things for the very early hospital care as we prepare patients for discharge, and then after discharge as they have their early outpatient follow-up care. And then more recently, in this viewpoint, was a sort of a follow-up where we talked about what are these different practices that have been identified for sepsis that can be directly essentially relevant to promoting recovery after COVID. And so I'm going to walk through some of these, what I think of as supportive care practices for our patients to promote recovery. And here are some of the things that we talked about in this perspective. First, anticipatory guidance, making sure that patients are aware of some of these common challenges and what are things that they can do themselves to promote recovery. Screening patients consistently for new physical, cognitive, and emotional symptoms that we know are seen in patients after sepsis and COVID. Optimizing medications at the time of ICU, hospital discharge, and sort of iteratively during their outpatient follow-up. Anticipating and mitigating these risks for preventable hospital readmissions, particularly volume-related heart failure readmissions. Peer support, there's like a growing movement within critical care to connect critical illness survivors to each other, to learn from each other, and also sort of share their experiences. Structured exercise program, I think, is important across the board, but what that looked like will differ patient to patient. And then a new thing that I did not talk about in this perspective, but I've increasingly realized how important this is, particularly from our My COVID-19 work, is screening for access to basic medical necessities. Because if patients don't have these, it's going to be very hard to recover going forward. So some of you may be thinking, gosh, but don't we do all these things already? These sound like what we already do. So I'm going to walk through some literature, essentially showing how commonly these practices are done across the board, and suggesting that I think there still is an implementation gap and that we can all do better to ensure the consistent delivery of these aspects of care going forward. The first is a survey of ICUs across the state of Michigan, where they were asked whether clinicians have formal discussions with patients and families regarding challenges or changes to their life after ICU discharge or after critical illness. And you can see that only about a third of the respondents said that they consistently have these conversations with many or almost all patients. And this is self-report among ICUs participating in a quality improvement initiative. So I think, if anything, probably overestimates how commonly these conversations actually happen in practice. But I think, you know, these are really important. I've pulled just two patient quotes. These are patients of mine that I see in outpatient pulmonary clinic that I have really kind of reinforced to me the importance of providing that anticipatory guidance when I see patients in the intensive care unit. The first patient said, well, when you don't tell me what to expect, I feel defeated every time I can't do something. This patient went home and sort of struggled to just like do their normal chores and activities. And the patient said, well, gosh, you know, no one told me it was going to be difficult. So I just assumed that everybody else did fine. And it was just my own personal failure. So we kind of felt like a personal failure after going home and struggling. And I think this reinforces about telling people what to expect. This next patient said, no one told me I was going to be short of breath. I've just been sitting in my chair waiting for it to get better. This patient had gone home and likewise tried to go about his normal activities and felt achy and short of breath. And when he had those symptoms, his immediate assumption was that, well, gosh, if I'm having those symptoms, it must be unsafe for me to move about, and I'll just sit on my couch and wait to get better. And of course, sitting on the chair, sitting on the couch, sort of intentionally decreasing one's activity level is not a good recipe for recovery. And so I think this quote to me highlights the importance of sort of counseling patients on the need to each day kind of like push yourself to do a little bit more than you were doing the day before and work towards recovering to your prior activities. This next study I want to share is a cohort study that was done. It's a chart review looking at 189 patients who had survived sepsis at the Carolinas Medical Center, and they did really detailed chart reviews to look at how often were medications optimized in the peri-discharge setting, how often were patients screened for common new impairments, how often were they monitored for common and preventable causes of health deterioration, how often were care alignment practices documented, and 46 to 65% of patients got each of these individual practices, but very rarely, only 11% got all 4 of these practices. The cohort in total had a 35% rate of hospital readmission and 17% rate of mortality at 3 months after discharge. And receipt of each of these individual sort of supportive care practices were each strongly associated with lower odds of hospital readmission or death. Again, sort of showing that there are implementation gaps and that indeed these practices are associated with improved outcomes. This next study, I think, speaks a little bit to these preventable hospital readmissions, specifically related to volume. So volume overload, very common at the end of septic shock hospitalization and not consistently acted on. This is a cohort study looking at patients hospitalized for septic shock and asking, what did things look like at the end when they're getting discharged from the intensive care unit? The vast majority of patients had a positive fluid balance, and a third of these patients were frankly volume overloaded, meaning that their body weight was more than 10% above their baseline weight when they left the ICU. And of these frankly volume overloaded patients, only 42% had gotten a diuretic or any kind of specific treatment to try to promote diuresis. This was important because the volume overload, even after adjusting for illness severity, was strongly associated with increased odds of new disability, inability to walk at discharge, and need for placement into a facility, which of course makes sense. If you mentally think about putting on 10% body weight over the course of 10 days, it's going to be harder to walk. And so I think there's a ton of attention on kind of like early resuscitation of sepsis and much less attention to kind of getting patients back to a euvolemic state and sort of assessing that, because there's a lot of sort of weight loss that occurs during the course of critical illness. So often we need to get patients not only to their baseline weight, but actually below that to be truly euvolemic. Next, in the My COVID-19 initiative, we've looked at how often primary care follow-up happens, and we're seeing that it's not happening consistently. So during the first wave, only 55% of our patients discharged alive saw a primary care physician within 1 month by any means, either telephone, video visit, or face-to-face. And then we looked a little bit deeper and looked at, well, how often were people scheduled for a visit prior to discharge? And during that first wave, only 11% of patients actually had a scheduled visit before leaving the hospital. Most of them were sent home like, please contact and make an appointment. And things increased a little bit during wave 2, 25% had a scheduled visit, but still we saw huge variation hospital to hospital. Some hospitals consistently make sure that their patients are scheduled for a follow-up appointment before they leave the hospital for all or nearly all patients, whereas other hospitals do that essentially never. They just send everybody home and say, oh, please make sure to schedule your follow-up after you leave. And so I think this suggests one opportunity, where we could sort of work to better coordinate care and ensure that timely follow-up is happening. This next slide speaks to medication errors. There's a large body of literature showing that medication errors are common at hospital discharge, but in particular in patients who are critically ill and spend time in the intensive care unit. So what we commonly see is that chronic medications are held. Things like diuretics are held because a patient is hypotensive or has acute kidney injury. But after those resolve and it's now appropriate to resume them, the medication is sort of forgotten and they become accidentally discontinued on a permanent basis. And likewise, we see that acute medications that are started as like sort of as needed medications for symptoms in the ICU, such as antipsychotics for agitated delirium, commonly get continued at ICU discharge, and then you see them just persist on people's medication lists. So I think that medication errors is a huge opportunity for quality improvement and something we'll be focusing on in our sepsis initiative going forward. The last study I want to share with you here is looking at discharge practices across 22 academic medical centers. And the upshot was that they saw substantial variation in terms of what hospitals are recommending at discharge or to be included in the discharge assessment or discharge plan for patients. And I'll just point out this one area in particular, that only about a quarter of these medical centers recommending addressing access to these critical supplies such as DME, medications, and food, which again, I think the MyCOVID data really suggests that this is an important sort of screening that should be done across the board in order to connect patients to social work and other support as needed. So I think I've tried to just share data with you to show that, these are important practices, and that, one sort of chart review study, they were consistently associated with improved outcomes. And then I think we've seen across the studies that there are implementation gaps and opportunity to improve in these supportive practices that are recommended really across the board for our patients after sepsis and COVID. I'll close by just sharing some resources. The top are articles related to best practices for recovery after sepsis and after COVID. This next article is a Society for Critical Care Medicine task force that examines screening tools that can be used to look for new cognitive, physical, and emotional symptoms after critical illness. And then there's a variety of different patient education and sort of anticipatory guidance resources to help patients and families learn about what they might experience after critical illness, after COVID, after sepsis. Next, I want to share this resource. This COVID-19 Caregivers Workbook was developed by researchers at the University of Michigan's Institute for Social Research. And this is a really unique resource because it was developed in conjunction with patients and caregivers who had experienced a hospitalization for COVID. So it tries to really be directly responsive to the gaps in anticipatory guidance identified by patients and families, and also be inclusive of pragmatic recommendations made by patients and families. So one of the chapters in this workbook is about specifically recovering at home after COVID, and includes sections on what can I expect while recovering? What are common issues following hospital stay? What is post-COVID syndrome? What are the long-lasting symptoms? How can I improve symptoms and strength at home? How do I find motivation to reach my goals? What are some feelings and emotions I might have? So I think really good content in this. And in addition to be able to download this University of Michigan version, there's also an editable version that you can download and essentially brand for your own hospital that's included in this web link included here. These same investigators are leading this heart study where they're collecting sort of stories and doing qualitative analysis about experience with COVID. And this heart website includes a lot of links to resource, including online peer support groups for patients experiencing symptoms, long COVID symptoms, as well as caregivers. So in closing, I hope that I have showed you that the CQIs are really a powerful model to understand and improve care that we were able to leverage to learn about COVID in a very timely fashion. We've seen that patients commonly experience long-lasting symptoms after COVID. It's not clear to me that this is worse than sepsis, but I think really highlights or reinforces the importance of sepsis survivorship at large. I've also talked about how symptoms really vary markedly from patient to patient, but our best supportive care practices can improve outcomes across the board. Implementation of these lags and therefore attention to these best supportive care practices can help to improve our patients' recovery today. I will close there. I'd like to thank you all for your attention. I've also listed a lot of my collaborators who were instrumental on some of the work that I shared today. And I'm happy to take any questions. Thank you.
Thank you so much, Dr. Prescott. Anyone who has questions, you can either type them in the chat or you can unmute yourself and just ask.
Hi, Caroline. This is Ananda. Can I ask a question?
Yes, please do.
Yeah. So this was a fabulous presentation. It was really, really remarkable. I really enjoyed it. So I'm a biostatistician, so I look at it, the QI projects for dialysis centers at the Kidney Epidemiology and Cost Center.
Yeah.
And we do a lot of quality things for the facilities. And something we try to do is to sort of look at the quality indicators for the facilities, where we do sort of SMR type of scores. So more like an observed or expected. And that's where the patient mix comes in. So if a hospital is taking care of a lot of older patients and sicker patients, they will have some of these outcomes also showing that, reflecting that. Is there an opportunity to do something like that where you actually take into consideration the patient mix?
Yeah, absolutely. I mean, I think that's one of the benefits of having this granular clinical detail as opposed to just relying on, relatively limited data from claims or administrative databases. So yeah, for my COVID-19, we worked with some collaborators actually in UM's Department of Biostatistics to develop like a predicted mortality model. So certainly we can use that. And then, the goal is once we have enough data in the sepsis, we're just in this like pilot phase, but once we have enough cases, we'll be able to do the same thing. So I think absolutely, like for the outcome measures, it's important to be able to risk adjust those. And then for the process measures, basically it's sort of whether it's indicated or not.
Right.
Yeah.
Thank you.
Yeah.
Any other questions? Please unmute yourself and just go ahead and ask or type your questions in the chat and I'll read them out.
Yeah, hi, this is Ellie Mulham from Beaumont. Just asking about for Hallie, what are the immediate research gaps that she sees in understanding the post-acute COVID syndrome right now?
Yeah, gosh, such a huge question and a great question. Yeah, I mean, I think there's a couple different things. I mean, I think there's like sort of specific symptoms that are more, unique to long COVID, like this loss of taste, this loss of smell, kind of headaches, maybe some of this autonomic dysfunction that's been described that I think are maybe more specific to SARS-CoV and viral sepsis and how to like best manage those. I mean, I see a lot of people, for example, with chronic cough after COVID in my pulmonary clinic, and it seems to be relatively unresponsive to everything I actually try. And tincture of time seems to be the best that we've got. But I think, we have enough people right now that are experiencing these individual symptoms that you could actually do some kind of randomized clinical trial to compare the efficacy of, different interventions. So those are sort of specific research questions. I think more broadly, there's this opportunity to think about the comparative effectiveness of different models. There's a lot of attention about kind of like post-ICU clinics or post-critical illness clinics. I'm not totally convinced that it's feasible to have those things at scale. And so I think there's this opportunity to look at, what are different care delivery models that would be sort of feasible, acceptable, sort of equally effective at supporting patients. And there are some studies, going on right now trying to look at that. So that, that study I showed about the 189 sepsis survivors was actually pilot work for an R01 clinical trial that they're currently doing at that sort of 10 hospital system in North Carolina, where they're having a remote kind of like discharge manager who like identifies these patients with sepsis and then tracks them across their course to like, and has like a list of kind of like best practices. And I think like pings the clinical team to make sure these things are happening. And it's both in hospital and after hospital. And so that is currently in the field and is enrolling about 700 patients. So that's another cool thing. And then last thing, and then I'll stop and let other questions come through. But I think there's been a lot of creative programs that have been put in place to try to address long COVID and also to try to monitor patients right after hospital stay. And a lot of these are just like different hospitals kind of did what they could. But I think it's a huge opportunity for sort of like program evaluation, understand which of these things worked well, which of them are scalable, which of them can be sustained, which of them should be sustained to not only help patients with COVID, but this bigger population of patients after sepsis. So I think that represents like a huge opportunity to learn from what we've already actually been doing. I'll stop there. I could talk for an hour.
Thank you. What about for primary care? What do you think the opportunity for primary care? Because we're seeing a lot of these patients, but we're not able to look at the data together. Any thoughts on that?
Yeah, I mean, I think that there's a huge opportunity, I think, for trying to fix the transition from hospital to primary care. Like, to me, it feels like there's this like vast gap that happens, and patients are sort of discharged, and I think they feel very vulnerable and alone. And a lot of these patients didn't even have their family in the hospital. And so it's not like only primary care, but sort of the conjunction between hospital care and primary care of like, how do you best sort of fill that gap? Like, how do you get the information to the primary care in a timely physician? How does the primary care physician like extract this information in a timely manner to sort of like pick up the pieces and continue to support the patient going forward? I mean, like I said, in this My COVID-19, we see a lot of patients just getting discharged. They have no one to call if something goes wrong because their primary care doctor doesn't yet know what happened to them, and they don't even have an appointment yet. And it just sort of says, oh, make sure you kind of like manage your follow-up going forward. And as I work in the pulmonary clinic, I sort of experience the other end of it, where patients call you and they just say, oh, I was in the hospital. Like, what am I supposed to do now? And you're like, I don't have any idea like what happened in the hospital. So it's very hard to make recommendations until I have at least that discharge paperwork. So I think there's a lot of work to be done about, is there a specific checklist of things that we need, or is there like phone call communication? There's just, I think, huge communication gaps that occur as we transition people through the system.
Thank you.
So Dr. Prescott, maybe you could just clarify, I think what we're looking for more is if somebody walks into our clinic, outpatient setting, and they have had severe COVID and been hospitalized, and we have the discharge summary on our computer, but they have multiple concerns and complaints, what are the top 3 priorities for that patient when they walk in the door, maybe 3 months or 4 months or 6 months after their discharge?
Yeah, great question. So, I mean, I still think that these kind of like basic supportive care practices are really the most important things to start with, because they're applicable across the board. So one, just sort of making sure that the patient understands what happened to them, and what might happen to them going forward. There's a lot of patients for whom like critical illness in particular is kind of like a black box, and they just kind of have like a gap of what happened to them. So sort of filling that in, I think, can be helpful. And then, what to expect going forward and what they should be doing, and sort of gradually trying to work to get better every day. And then the medication reconciliation, I think, is huge. We see sort of consistently time and time again about these kind of like temporary symptom medications continued and these chronic medications discontinued. And so I think that like to give the patient the sort of time and space to recover before they have like a second hit and get rehospitalized, I think it's that sort of providing the anticipatory guidance. And like, if I could put my money on like one thing, it would be this kind of like comprehensive med list focusing to getting the cardiac medications that are sort of highly indicated back on, and then getting these temporary symptom things that seem to sort of get stuck on their med list off.
Great. Thank you. Any last questions for Dr. Prescott before we let her go and move on with the rest of our morning? All right, with that, we will say thank you very much, Dr. Prescott, and we really appreciate it. I think, this was the long COVID was one of the major requests and concerns for all of the people on our planning committee for this conference, and we're really looking for more information. You guys have a conference coming up for the state of Michigan's COVID response in a few weeks. Is that right? Do you know about that? Like in June 12th or something like that? There's going to be another presentation on COVID-19 on Michigan COVID-19 results, and we'll get that information out to everyone. So maybe with some more details and some more updates as we go forward. So Michigan COVID-19 CQI is still continuing to collect data. We'll still be getting more details out, and those are available. Just want to clarify one more thing for the CQI data on COVID-19. That data is available to researchers across the state if they have an interest in looking at some of the data, right? And so this is statewide collaborative data. It is available to researchers as needed. Obviously, these are clinical data, not research data, so they're they're protected by HIPAA, and de-identified data or summary data may be appropriate. And if you want more detailed data, that needs to have a collaborative agreement and IRB approval as usual for all research. But this data is very valuable, very detailed, and it is not proprietary of the University of Michigan or Dr. Prescott's group or the CQI or Blue Cross Blue Shield or anybody. This is a public resource, a collaborative resource, and it is available for people to use if they're interested in answering specific questions.
Yeah, that's right. I'll send my slides to Blythe, but the link for the My COVID-19 homepage has a portal to put in requests for data. And so essentially the data request just sort of broadly has to support the missions of the CQI, which is to improve care and outcomes of patients with COVID-19, which that would be the main reason people would want the data. So yeah.
Great.
Yeah.
All right. Thank you very much. And we are going to move on. All right. And all right. Can you guys see my slides now?
Yes, Caroline, we can.
Okay, perfect. All right. So sorry about the initial technical difficulties. I just wanted to go through a couple of things. Let's see. All right. Oh boy, this still is not working properly. You can see my slides, right? All right, here we go. Now you should be able to see. Okay, so just since I didn't get a chance to introduce Dr. Prescott initially, just here's some of her information, and we'll give you more detailed stuff about her work in the future. I want to shift briefly to talking a little bit about, for about 15 minutes, about research resources for family medicine in Michigan. And while we don't have a lot of interactive opportunities during this conference, you can help us by, if you have a research resource for family medicine that's relevant to researchers in Michigan, you can add it to the chat. And I'm going to talk about 3 resources that I think we should all know about and that are valuable for family medicine researchers in Michigan. So my first one is the Michigan statewide CQIs. And Dr. Prescott already talked about the one Michigan COVID-19 CQI, but there are many more, and more are coming. And one of the reasons we picked this topic to discuss was that the new ones that are coming out, the new CQIs that are being started right now and are being developed, are outpatient focused and chronic disease focused. So actually much more relevant to family medicine researchers than the previous CQIs, which were focused on primarily hospital-based medicine, surgical procedures, and with a few of them focused on transitions of care to outpatient, but none really focused on outpatient work. So recently, Blue Cross Blue Shield has made a new initiative to start focusing on chronic diseases and outpatient settings for quality initiatives. The very first outpatient focused quality initiative that is funded started in January and is still really in its planning year. And that's MCT2D, or the Michigan Collaborative for Type 2 Diabetes. And so I'm the lead for the MCT2D. And so I've been getting familiar with how these Michigan collaboratives work and starting to develop this project statewide. And we hope to actually have quality initiatives in place in January of 2022. So one important thing to understand about these quality initiatives is that the old ones were focused on the hospital and collected data in the hospital on patients. The new ones, because they're focused on outpatient populations and chronic disease management, for one thing, we have a much larger number of patients to deal with. Over 1 million patients in Michigan have type 2 diabetes. The other thing is there's a lot more settings, primary care settings, independent practices across the state of Michigan, rather than just the large hospital and health systems. A lot more places to get data from. We're going to include physician organizations, hospitals, and individual practices and physicians. And we're developing a new model of a CQI data hub, which will collect all of the clinical data from across the state. And we'll talk about how that's going to happen as well. More traditional CQIs had smaller populations. They focused on specialists, mostly hospital-based, and they used a registry system, and we are not doing that. So just to give you a little bit of information about the diabetes, the type 2 diabetes CQI, we're looking at the current standard of care where people tend to approach type 2 diabetes as if it's mostly a genetic risk disease. People aren't really very good at changing their behaviors. Very few are successful, and really type 2 diabetes cannot be prevented. That it's a gradually progressive disease. The best we can hope is to slow the progression and reduce the risk of complications, and that it cannot be reversed. So that's the sort of the old paradigm, or what we're used to practicing in, and what patients and physicians often fall back on. So the Michigan Collaborative for Type 2 Diabetes is really focused on a new paradigm, which is to prevent and reverse type 2 diabetes. And we have really pretty convincing data that these things are now possible. And we're focusing on 3 initiatives. One, new medications, GLP-1 receptor agonists and SGLT2 inhibitors. The second is using continuous glucose monitoring in type 2 diabetes to help support improved care, and then lower carbohydrate diet interventions as well. So those are our 3 pillars that we're starting with. We're also going to focus on prevention of type 2 diabetes. And then the data model that we're using involves a statewide collaboration for data from all of our healthcare systems. That's called MyHEN, the Michigan Health Information Network, and also the Michigan Data Collaborative. These are big data hubs that collect data from all the health systems across the state through electronic medical record data transmission. It's automated, very detailed clinical data. That's the way we're going to be learning about who has type 2 diabetes, how are they being managed, and is the care improving across the state. And so that's a new way of thinking about quality CQI data. The type 2 diabetes MCT2D is the first outpatient focused collaboration, but there are many more that are coming on board. 3 different collaboratives that are already active and starting their work one's called HBOM, the Health Behaviors CQI, which is focused on smoking cessation, diet, and exercise management. And they're really working in collaboration with the other CQIs, including MCT2D, to help measure and improve health behaviors. There's a Michigan Kidney Collaborative also working closely with the type 2 diabetes group, focused mostly on chronic kidney disease. And M-Shield, a social determinants of health collaborative, focused on collecting data around social determinants and looking at ways that the health system can intervene to improve health outcomes through social determinants interventions. In development, but not yet started, are CQIs focused on COPD management, on women's health care in the outpatient setting, and on palliative care. So all of this data hub on chronic diseases, collecting data from patients across the state, is going to provide us with a lot of valuable tools for learning and improving care across the state, but also potentially for research and expanding our understanding of how some of these interventions are working. Again, this data is collaborative data statewide, available to anyone who wants to work with it under the appropriate restrictions of patient confidentiality and IRB rules. It's not proprietary. It is for the betterment of the health of the people in the state of Michigan. And it is available to all of you as researchers in family medicine as well. So that's the CQI program. There's two other research resources that I really just wanted to mention. First is an issue that was published in 2019 of a journal called Family Medicine and Community Health. And I've got the URL there on the slide. And this issue is full of articles, which are methods articles about how to do research, family medicine focused research. And it's about 15 articles with very in-depth and thorough and methodologically focused articles about how to do different kinds of research, anywhere from doing qualitative interviews, mixed methods research, basic statistics, all of those things are detailed. It's really a fantastic resource for people who are starting their work in family medicine research. And I highly recommend that for teachers and learners in family medicine. The third one is the Annals of Family Medicine. The Annals of Family Medicine is the leading journal for family medicine original research in the world. I'm currently the editor-in-chief of that journal, and the journal editorial staff is housed at Michigan Medicine. That's new as of 2 years ago. We took over the journal about 2 years ago now. And we are available to you for questions or ideas about what you'd like to see published in the Annals of Family Medicine. We need help with reviewing and writing editorials, commenting on our articles. We have our main focus is original research manuscripts, and that's what most of our journal is. We focus on clinical research rather than on educational research. That tends to be given to the Family Medicine Journal, which focuses more on education. There are two kinds of articles that we also publish quite frequently that you may be interested in. One is called Reflections, and that's essays about what it's like to be a family doctor and how your interactions with patients affect you. And then the second one is Innovations in Primary Care. And that's just very brief, one-page summaries of something you've tried in your health system or clinic that seems to have improved care systemically for your patients. And you can check out how to structure those different types of articles on our author instructions page as well. And we're happy to answer questions. So that was my three focus on resources for family medicine research points. Does anyone have any others that they'd like to bring up? You can unmute yourself and talk, or we can just put them in the chat. All right, I'm going to go on then. I was supposed to do this at the beginning, but since I couldn't get my technology to work, I'm going to do it now. The 2021 Michigan Family Medicine Research Day committee members are listed here. This was a collaborative effort. This is our first ever virtual family medicine research day. And it took a while for us to figure out exactly how we were going to do it. We relied quite a bit on our design and technical lead, Noah Kim. Many thanks. We would not have been able to do it without them. And all of our presentations by our participants are pre-recorded, and they're available theoretically forever at this website. So you can send links to your mom and dad or whoever you think might want to watch it. There are also opportunities to post public comments on each of those presentations. I also wanted to thank our judges who went through and reviewed all of the pre-recorded presentations and helped us to pick award winners for each of the categories we have. And I'm going to go ahead and move forward to the award categories now. And for each award category, we're going to have a presenter from the institution of the winner is going to going to tell us about the title of the award and the award winner. All right. So anything we need to do before that? Any questions or concerns? All right, we're going to go ahead then. So for the award ceremony, the first award that we're going to give out is for best oral presentation from a graduate student, and Dr. Zhu is going to give us that award information. Hopefully.
Okay, yes. Thanks. I need to go to a different view. Okay, the first award goes to Sara Parker, Wayne State University. Her title of the project is Influenza Vaccination Coverage Among Children with Asthma. So congratulations, Sara.
Sarah, if you are online, if you could unmute and say hi so we can.
Hi, yes, thank you very much.
Great.
What an honor.
Thank you, Sarah. Okay. Our second.
You can all feel free to turn your video on as well for a moment if that is good for you.
Okay. My camera.
All right. For our second award, our second award is for best oral presentation by a medical student. I'm going to go ahead and talk about that. That's for Kaila Helm from the University of Michigan for understanding the barriers and facilitators for audiology follow-up, a secondary analysis of early audiology referral in primary care. Dr. Helm, are you online and can you turn on your video and unmute and say hi? Maybe not on today, but congratulations, and we'll catch up with her later. All right. The third presentation, the third award is Best Oral Presentation from a resident focused on acute care. And that award is going to be discussed by Dr. Arnett.
Thank you. And the award goes to Sara Wisniewski from the residency program in Midland for the work titled Appropriate Use of Caprini Score in the Hospital Setting.
Dr. Wisniewski, are you on? Can you unmute and show us your video?
Hi, thank you.
Great, congratulations. All right, and we are going to move on to the next one, which is Best Oral Presentation for a resident focused on outpatient care. And the winner of that award is Brian Anker of the University of Michigan. Dr. Anker, are you on?
I believe he is on vacation, Caroline.
He's on vacation. Well, that's a good thing. We will catch up with him later as well. Next is Best Oral Presentation from a resident focused on health disparities. And that is Kate Mexner. Dr. Mexner, are you on?
Hello. Thank you so much. I'm so honored and surprised and feel so grateful for the award. Thank you.
Congratulations. And the title of Dr. Mexner's award is Health-Related Quality of Life for People with Acute and Chronic Illness During COVID-19 Pandemic. So relevant to our talk. All right. Next award is Best Oral Presentation from a resident focused on practitioner education. And that's back to Dr. Arnett.
And the award goes to Daniel Hillman for the work entitled The Implementation and Physicians' Perspectives of Social Determinants of Health within a Residency Program Setting.
Well, thank you all very much. I appreciate the acknowledgement.
Congratulations, Dr. Hillman. And next award is Best Poster Presentation by a Faculty or Staff Member. Again, Dr. Arnett's.
Yep, and this award goes to Samantha Eli for the poster entitled An RCT of a Remotely Delivered Psychological Intervention for Youth with Childhood Onset Lupus, partnership with a patient caregiver co-investigative team.
All right, and for the third Michigan State University in a Row award, we're going to get back to Dr. Arnett's also for the best poster presentation by a graduate student.
And the award goes to Mallet Reed for his poster on social systems of discrimination and disease, an ecological approach to understanding and addressing health disparities in lupus.
All right. Dr. Reed, are you on?
I just wanted to say thank you on behalf of him. I think he had a conflict, class conflict during this time, but we really appreciate the recognition.
Great, thank you and congratulations. All right, moving on. We have a best poster presentation for a student focusing on adolescent health, and that's Dr. Zhu.
Yes, this award goes to Deepika Bhaskar. The title of the project is Assessing the Acceptability of an e-health intervention to improve diabetes care among emerging adults with poorly controlled type 1 diabetes. Congratulations, Deepika.
All right, and also from Wayne State, our next award winner is best poster presentation for a student in health disparities. Dr. Zhu?
Yes, this award goes to Sara Nesser. Her title of the project is Identification of Cirrhosis in a Predominantly African-American Patient Population Using FibroScan. Congratulations, Sarah. Are you here?
We will catch up with Sarah later. Thank you. And our next award is Best Poster Presentation by a Resident. And that goes to Dr. Brianna Marzoff for our medical students adequately trained to care for persons with disabilities. Dr. Marzoff, are you on? Can you unmute and say hi? Not on, perhaps in the hospital somewhere. All right, continuing on. We have best case report for a student, Dr. Hauser.
Hi, this winner is Rachel Schooley for her poster on hypervitaminosis B6. Congratulations, Rachel.
Hi, thank you so much.
Congratulations. All right. And our last award is for best poster case report from a resident, Dr. Arnett's.
And the award goes to Catherine Mirzai for refractory erythema multiforme in a pediatric patient. Congratulations, Catherine.
Dr. Mirzai, are you on?
She's currently on service.
Okay,
but on her behalf, thank you.
Okay, great. Thank you, everyone. All right, well, that wraps up our award ceremony. Congratulations, and thank you all for participating in this unusual way of doing Michigan Family Medicine Research Day. I will say that we have planned for our future dates for the Michigan Family Medicine Research Day for the next 5 years, and here's who's listed as hosting. Who knows what will happen in 2022, but we hope that these will be in person again, and we will be allowed to see each other face to face and have more interactive content and also better food. Until that time, this presentation is completed. Any last comments or thoughts?
Thank you, everyone. Thank you, the organizers.